Good afternoon. My name is Dr. Randhawa, and I'm the founder and chief executive officer of the Southern California Food Allergy Institute. And I wanted to take another minute or two to give you an update as to what is going on in the world of COVID-19. Once again, I think we're in a situation where a lot of information is fragmented, information is coming from various sources, and with that, it becomes very difficult to understand what is accurate information. I think we are in a serious situation in regards to the spread of this condition, but the information that's coming out of various countries that is now actually being published in peer-reviewed journals from January and February has been very interesting and eye-opening. So I'd like to first start with that. The good news is, as I mentioned last time, that children, again, are exceedingly low risk. We have a number of different publications, one that actually was just recently published in the journal Pediatrics that showed 90%, again, 90% of children, pediatric cases, were considered basically mild to moderate. And these are kids who actually contracted positive COVID cases, and these are studies with 4,000 or more children. Interestingly, there were a small group of patients, particularly young infants, in the initial area that was impacted by the virus in China, who seemed to have more critical findings. But again, these children did relatively well. And to date, there has been at least only one reported pediatric fatal event. And that, again, is across the board very good news for the pediatric population. I encourage everyone to be really careful about the information that you're processing. Understand that much of the information is available on proper scientific resources so you can make better decisions for you and your family. So again, the mortality rate, not only for kids is exceedingly low, but even the mortality rate for adults is very clearly under 1%. And that's a good sign. It tells us that even though this virus's behavior was initially quite rampant and quite negative towards certain folks in the adult population, it does appear now to be less rampant, equally infective, but at least less rampant towards the mortality side of things. More information of that is yet to come. In fact, if you look at the pediatric to adult ratios, you would actually have to see amongst patients who tested positive about a 70-to-1 ratio. That means 70 adults will be positive to one child that is positive. So we do see this discrepancy where children don't seem to actually contract this illness as well. So I hope you find that information particularly useful. Secondly, I wanted to give you some specific recommendations for children who are in our program. First of all, follow government recommendations. Obviously, we've made a lot of changes here at SoCal Food Allergy to accommodate our patients as they come in for their treatments to make sure that we appropriately distance ourselves and wipe down and disinfect appropriately at the maximum level, similar to that of a hospital setting. Secondly, I encourage folks who are able to keep your appointments because we are not considered non-essential. Remember, if your child is in actual therapy, this is a form of medical treatment. And indeed, if you're in active treatment, even in the earliest forms of active treatment, we are already changing your child's immune system, which means the duration of time is key. We cannot leave children on indefinitely long periods of dose exposure that is actually negative towards the patient's endpoint outcome. So again, you have to use your judgment as to how things are impacted in your particular locale. But overall, if you can keep your appointments, this is considered essential medical treatment, which is, again, best for children. Lastly, I wanted to talk about guidelines for children. I think a lot of information out there is unclear. If your child is sick, what should you do? If your parent is sick, what should you do? If your grandparent is sick, what should you do? So what I've done is compile all the aggregate data and some of the initial consensus guidelines into 3 very simple slides for you to understand. I'm going to walk you through them, and I encourage you to actually utilize these as a resource. Utilize them with your physician to help make best decisions, to understand what testing is needed and who should be tested, and how quickly you can expect changes in recovery rates and so forth. So again, I hope you find this helpful. Thank you. So the first slide that I would like to briefly go through is titled Low Risk Patients. So who is low risk when it comes to COVID-19? Essentially, it includes children, it includes young adults, and really anybody up to the age of 60. I think if anybody has any other major medical illness, particularly diabetes or very high blood pressure, and you're under the age of 50, perhaps you would not be considered low risk, but per current information and data that exists, low risk patients would generally be considered anybody under the age of 50. So if you're in a situation where you think somebody you know under the age of 50 is potentially ill, you first want to ask yourself, are you symptomatic or not symptomatic? If you're not symptomatic and you're just in a state of quarantine, in general, all you have to do is just wash your hands and avoid crowds. That's the best thing to do right now to stay safe. If you're in the symptomatic group, you want to pay attention to two primary symptoms. One is fever, which usually lasts for 6 to 8 hours. These are not low-grade fevers. And shortness of breath. And if you see fever and shortness of breath, remember that in low-risk patients, you do have some time. You even have up to 2 days to really get a sense of how you're feeling. And if you're feeling better after 2 days, you're improved or recovered, you don't need to take any further action. Because if it is COVID-19, it does not resolve that fast. If you are, after 40 hours, not feeling well, you are not stable, it's important to see your doctor. You go see your primary care doctor, and at that stage, the primary care doctor will take some vital signs, check your oxygen levels, they will assess you, and make a decision. And at that stage, especially for young children, you want to make sure they don't have a common infection. Do they have an ear infection? Do they have a sinus infection? Do they have a throat infection? And if they don't see those common infections, they should really consider running a respiratory viral panel. And what that is basically a rapid test for influenza, but not just influenza, preferably you want to test against other common winter viruses. Why is that important? Because co-infection with COVID is exceedingly rare, period. So what that means is if you're positive for another infection like a sinus infection, or if you're positive for, let's say, rhinovirus or the common cold, you don't have COVID-19. You go down the path of another infection is present, you treat that infection, no further action is needed. However, if you don't have another infection and your viral panel is potentially negative, then you want to reassess again in about 48 to 72 hours. At that stage, you want to ask yourself, do you feel like you've improved or recovered? You probably want to get your physician to participate in that discussion. If you've improved and fully recovered, no further actions needed. However, if after that additional 48 to 72 hours you are not stable, that's when you want to really start digging deeper into the problem. So that includes utilizing blood work. There's a number of different inflammatory markers that have been seen to be useful in diagnosing patients who may have COVID-19. You want to repeat a respiratory viral panel because sometimes the first round can be negative and the second round is positive. And at that stage, it's a discussion about running the actual COVID nasal swab. And during that time, if that workup, or that testing that is done is positive, and the patient is COVID positive, that's when you're going to be in a situation where you are considered an actual case, and determination of hospitalization versus a home-based quarantine is a discussion between your general pediatrician or your general doctor and the CDC, as well as other respiratory findings. So essentially, you have to go down this entire pathway to end up in a situation of being at highest risk. And clearly, the vast majority of patients who are exposed in low-risk situations would never end up in this high-risk situation. They would simply be recovering at some other point of this path. And I also wanted to take a minute to review what would be a good set of decision-making points for patients who are actually high risk. So this is for folks who are seniors over 65, folks who have diabetes, folks who have high blood pressure or other cardiovascular disease, stroke, and in particular, autoimmune disease or significantly immune compromised states. These patients are high risk. Again, these are patients who are generally older and have other medical conditions, and either you're in the symptomatic category or asymptomatic category. The main takeaway points for the asymptomatic category is make sure you talk to your physician, make sure this individual has all of their current medications actually at home, and make sure any sort of lung support that they need is available to them at home. So you don't want to have to be in a situation where a person is not doing well and they don't have their basic nebulizer or basic inhalers available for them. And then obviously they're just going to follow the standard precautions and stay in an asymptomatic form is the goal until this virus passes on. If the patient, who again is high risk, becomes symptomatic, again, it's typically greater than 8 hours of fever, not between 6 and 8, but greater than 8 hours, and usually a very low productive cough. And usually the cough follows the fever. At that stage, you don't want to wait. You're a high-risk patient. You want to see your physician. You want to get a lung exam. You want to get an oxygen level measured, and an assessment has to be made between your physician and yourself. And again, if you're stable, there is some time to watch and monitor. But if there is any sort of instability, the most important thing to do is rule out another infection. So they will check a respiratory viral panel to determine if there's any other infections that are present. If they are present, they will simply treat that infection, and you will not have COVID-19. However, if your viral panel is negative, then there is a significant amount of risk that is present in this category of patients. So they need to be reassessed in 24 to 48 hours, and they want to undergo 2 tests. The first test is a chest x-ray. The second test is a COVID-19 nasal swab. In any of these potential outcome cases, you're either positive or negative on those 2 tests. So the best outcome is you're COVID negative, you're chest x-ray negative, you're basically both negative. Those patients can be reassessed every 48 hours until they're stable, or they can be reassessed every 48 hours until you see another infection that you're actually technically treating or trying to find the source of the problem. If your COVID is negative and your chest x-ray is positive, chances are you have some other infection. It could be pneumonia. It could also be an inflammatory condition like asthma, and that requires your physician to manage and treat. If you're COVID positive and your chest x-ray is negative, that's where there has to be a discussion between the physician and the patient, and they have to determine whether they quarantine at home. They have to report that to the CDC, or if they're at a level of risk, they should undergo a CT scan of the chest. That will help determine whether they get admitted to the hospital or not. And the last is the highest risk situation where you're COVID positive and your chest x-ray is positive. Those patients should undergo CT imaging right away. Is one of the most helpful tests you can do to determine the progression of the condition as far as how seriously it can progress. And then that information is recorded to the CDC, and the determination is made at that stage to likely get admitted to the hospital or not. Thank you.